Yes, Dr. Babu, this is the 100th webinar.
Congratulations, sir.
Thank you, thank you.
Good evening, sir. Good evening.
Good evening, Umar. Good evening.
Sir, the 100th?
100th.
Oh, very good. Great.
Yes,
Congrats,
sir.
sir.
Congratulations, sir. Congrats, sir.
Firoz ഉണ്ടല്ലോ, Firoz.
ഉണ്ട്, sir.
We'll start for just 2 minutes more. We'll start, okay?
Yes, sir.
ഇടയ്ക്ക് ഓരോന്നൊക്കെ ഇല്ലാത്തതൊക്കെ ഉണ്ട് സാറിന്റെ ഓരോ സമയത്ത് തുടങ്ങിയത് ഇടയ്ക്ക് സാറ് ഇങ്ങനെ എന്തെങ്കിലും പനിയോ അങ്ങനെയൊക്കെ കുറേ ദിവസം ഇല്ലാത്തത് വന്നു അതായത് 4-5
I think we'll start now. Okay, good evening to all of you. Sorry. This is the 100th seminar, 100th meeting on this challenging case series. So as usual, we'll start with the short case first. Is my screen visible to you all?
Yes, sir. You can start.
Okay. So I'll start the short case now, ultra short case. This 23-year-old obese individual was under treatment for hypertension for the last 2 years. In fact, he had no neurological complaints. He went to the physician and the physician asked for a CT scan of the head. Then the indication, I asked him why he took a CT scan for. He has no, he said, I had no complaint. He's in a headache, no headache. Then he asked why the physician took the thing. He said it's only for completion's sake to take a CT scan of the head. So examined him, I could not find any neurological deficit. So this is a CT scan of the individual brought by the patient. He's a known hypertensive. He's only 21 years. This is the CT scan. The lower cut, I'll go one by one. This is the cut one above. Hypodensity in the external capsule, internal capsule, periventricular white matter. The splenium and the corona radiata. This is hypodensity seen, and there is in this area should feel more hypodense than the rest of the areas. Other things symmetrical white matter, this hypodensity. So what do you think at this point of time? Yes, when you want to communicate with the CT scan, what will you do?
This is white matter edema.
Yeah.
So go for an MRI with contrast.
That's the thing. Actually, I also said the thing. I don't know whether it's run. Yeah. Yes. Yes, Umaria.
Sir, this looks like a leukodystrophy.
Yeah.
Oh, the other possibility would be a cadacil, sir. But we have to follow up this case.
Right. So in fact, I thought this could be leukodystrophy or cadacil. But anyway, cadacil I did not suspect at this point of time. Maybe some leukodystrophy. Some of the leukodystrophy pattern can remain asymptomatic for long without any symptoms. Okay, so as which you are telling, so I do a CT MRI in this patient. This is the MRI of the scan. Okay, this is the lower cut. This is the T2-weighted sequence showing the hypertension in the external capsule, and also in the lentiform nucleus, periventricular white matter. You can see in the corona radiata and the periventricular adjoint in the frontal horn, lateral horn. And this area is a little more hypointense, maybe in fact there, hyperintense. This is upper cut. This is uppermost cut. I'll show the other sequence also. This is a coronal T2, showing the symmetrical hyperintensity bilateral. This is the flare, again going from below upward. You can see the cross hyperintensity in the periventricular region, lentiform nucleus, periventricular white matter, external capsule. In the corona radiata. T1 weighted shows hypointensity in the same area, but not marked as is in the CT scan. Diffusion. There is no diffusion restriction. It is hyperintense in both diffusion as well as in ADC map. This SWI, which shows microbleeds in the basal ganglia here. Sometimes few basal microbleeds in the subcortical areas as well. And mainly in the basal ganglia region, the microbleeds are seen. MRI is taken now. So what do you think the possible diagnosis is?
Cadassil.
Yeah. I also thought cadassil, that's a possibility. Any other opinion?
Vasculitis, but there are no symptoms. There is an infarct which is there. An old infarct is there, so it could be vasculitis.
Yeah, but only thing is symmetrical, no? The vasculitis is such exactly symmetrical pattern bilaterally occurring. See, all the findings are symmetrically present. If you look, go back, see, they're all almost symmetrical. And the cortical infarct is not there. In the vasculitis, why should occur only cortical, subcortical, and find a subcortical white matter?
Most cases of cadassil also is not, they're not symmetrical, no? Cadassil also not symmetrical.
Yeah, most of them are symmetrical, but can be asymmetrical also. But the vasculitis usually is asymmetrical.
So the other possibility would be some metabolic or mitochondrial. Metabolic or mitochondrial.
Okay, but there's no diffusion restriction. Usually mitochondrial produce diffusion restriction. And again, the usual affection of mitochondrial is basal ganglia. Here, subcortical white matter is also affected. That can occur leukodystrophy when in mitochondrial. And even Merla's type. That this picture is little different from what you see in the Merla's.
Old age, this could be finding in amyloid angiopathy with the vasculitis. Amyloid vasculitis, they say.
But he's only 21 years.
Yeah.
He's only 21. Boy.
Sir, any history of toxic exposure?
Yeah, that's a good thought, but there's no history, history like there's only hypertensive and medication.
You have to consider leukodystrophy, sir.
Yeah, one possibility is a leukodystrophy, which you have to keep in mind that possibility. But you can see the classical external capsule involvement is there. And there's one area of infarct is also there.
Sir, is he using any recreational drugs?
Pardon? No, not on drugs. No. Okay, what do you want me to do now? Any genetic test for cadassil?
I think so.
MRS.
Okay.
MRS.
MRS, I don't think I have done that. With suspect mitochondrial. Okay, I thought cadassil is one good possibility. This is my possibility which I considered. So this is a report from the radiologist. Cadassil, subcortical atherosclerotic encephalopathy is the radiologist opinion. So genetic test was done. That was negative for cadassil. There is no Notch3 gene seen. Then what do you think?
Any amino aciduria or something like that? Amino aciduria.
Okay, amino aciduria. But you get no other features in this patient, no other symptom, nothing.
Any family history of cognitive decline?
No, nothing. No family history, nothing.
Vasculitis.
Vasculitis profile was sent, that is not negative.
So what about his homocysteine, sir? Homocysteine? Normal?
Did not do. I did not do. But this typically Binswanger's disease. See, remember, he has got a hypertension. In hypertensive individual, you find the involvement confined to the subcortical white matter intestinal capsule. This is suggestive of Binswanger's disease. Now, the point against the Cadacil, which I initially thought Cadacil only, is that there is no hyperdensity in the temporal lobe. That was not there in this patient. That is one important finding which you get in Cadacil, which is lacking in this patient. Okay, this is the MRI picture of Binswanger's from literature, from such literature. This is Binswanger. See how symmetrical they can be in Binswanger's. If you look at that, it can also have the external capsule, just like our patient. So he being a hypertensive and with microbleeds in the subcortical white matter, microbleeds are unlikely unusual for a leukodystrophy and mitochondrial disease like that. Vasculitis, yes, microbleeds can occur. But the picture is symmetrical, bilateral, subcortical, that makes vasculitis less likely. So in fact, this picture is very much like a Binswanger's disease. Nothing related to the, it may be most likely related to the hypertension.
Sir, is it possible the cause could be adrenal leukodystrophy because of any contrast given this case? Sir?
Contrast MRI, I don't know. It was not given. Contrast not given. But the picture, you see, it's not like a adrenal dystrophy. Usually, adrenal dystrophy either in the frontal or palate-occipital. The pattern is entirely different. And the infarct you can't explain. The microbleed you can't explain with any kind of leukodystrophy. And the site of microbleed is typical of hypertensive microbleeds. Yes?
So the cause of hypertension?
Say young onset.
Young onset hypertension. In fact, he was investigated for secondary cause by the physician. He could not find anything.
How long is it?
2 years. 2 years has been on hypertension. More than 2 years.
But only 2 years.
But we don't know. No,
too much.
He was detected to be hypertensive for 2 years. How long it has been there before, we don't know. Nobody will take BP in a 18-year-old boy, no? It's just routine checkup, he will not do for BP. Some more other. Pardon?
Why did he go for routine checkup at 18 years of age?
Why did he go for that? I don't know. He's already on treatment. In fact, the boy was referred to me by the physician seeing the CT scan.
No, initially, why he went to the physician?
That I don't know. I don't remember because I did not ask why, what made him check the BP. That part I did not ask. I asked why did he take a CT scan?
Sir, is the MR angio normal? Angiogram normal?
MR angio was normal.
Sir,
if we can do it, I think we can do a clinical exome analysis. Clinical exome.
Clinical exome was done?
If we can afford clinical exome.
Clinical, it's picked up. Clinical exome is the one which I did. I did for clinical exam as well as mitochondrial genome testing. This is the mitochondrial genome. This is the clinical exome. This is the clinical exome.
Sir, can such things can happen in the family? Screening the family members, would that do any?
Yeah, that will, family member screening will help you to find out about the Cadacil. In the Cadacil, you can have family members who's got MRI findings can be positive, who may be asymptomatic doctor. In the person with the Cadacil, if you screen the family members, they can have MRI abnormalities in them without any symptoms whatsoever. But anyway, gene test is negative, so the possibility of Cadacil is now.
Sir, is there any evidence of any urine microalbumin or something? Because endotheliopathic may present like this.
Yeah, right. Because that's the cause of secondary hypertension. But in fact, it was investigated by him that was negative. He did not find any real problem.
Sir, has seen any patient like this so young having a Binswanger's previously?
No, I don't see. I not seen, frankly, I not seen. That's why I brought the case table.
Usually it is seen in long-term hypertensive patients.
Correct. Right. In fact, our radiologist suspected this thing. Radiologist seeing the MRI before the gene test came. So I was discussing with him whether this could be cadacil. Then he said the point against cadacil is this thing. You have to think of a Binswanger subcortical secondary to hypertension. That's what he said. And if you look at the literature, that picture is exactly same as our patient.
So one doubt, sir, but should we consider Binswanger only by MRI? We should also have some clinical symptoms, no, sir? Some memory impairment, vascular decline.
It is correct. Usually they have features of gait problem or memory problem should be there. But you find this that can come later on. He has got a good brain reserve. That is why he's not manifesting. In older individual, if it has this kind of picture, will definitely produce memory loss and gait problem. He's an youngster. That's why he could tolerate this much amount of subcortical white matter abnormalities very well. He has no neurological deficit.
This could be still only hypertensive changes, so chronic hypertensive changes. We don't know since when he's having hypertension.
We don't know.
Hypertensive causing these infarcts and white matter changes. Could be simple only hypertension only, sir?
It's only hypertension. No other symptoms.
No, the MRI can be only due to hypertension, chronic hypertension with encephalopathy.
Yeah, I call that, but this MRI picture is what is described as subcortical atherosclerotic encephalopathy. This is confined only to the white matter subcortical. That's the MRI picture is the one which is sensitive of Binswanger. What you said is correct. It is all due to hypertension. MRI picture is due to hypertension. This MRI picture is that of Binswanger.
But can we name him as Binswanger? That was my doubt, sir.
Yes, you can name. No problem. Otherwise, what can we call this kind of MRI appearance? Okay, shall I go to the next case?
The clinical presentation again, sir.
No, yes, no complaint, no neurological complaint. A CT was done by a physician routinely and he found abnormality and then referred.
This is to be said as Binswanger's or leukoariosis. Leukoariosis is the radiology picture and Binswanger's is a clinical syndrome. No?
In fact, leukoariosis is the picture little different from what you find in Binswanger's disease. Binswanger's picture is something similar to that, almost symmetrical, white matter, periventricular, external capsule, like that they come. In leukoariosis, confined only to the subcortical white matter away from the ventricle. That is the picture they get in leukoariosis. Oh, okay, all that way. In a sense, they are all similar way.
Yeah, same
condition.
So is the obese patient?
Obese, very obese.
So sleep apnea, history of sleep apnea, is it there?
That part I did not, frankly, I did not ask. I should have asked.
Actually, history of sleep apnea can produce hypertension in the young, sir. Obese.
Yes, of course. That of course. Yeah.
So you might be having this for quite a long time.
Correct. That is sensible. Yeah. That may be the reason for this hypertension, maybe primary hypertension. Okay, I'll put another case.
Yes, sir.
Okay, this is a long case. Story of a 27-year-old male. He gave history of transient paresthesia lasting for 2 minutes, occurring on the left side of the body 2 months back. Such episodes occurred 3 to 4 times during the last 2 months, always confined to the left side, lasting for 2 to 3 minutes and subsides. He noticed paresthesia the whole of the left upper limb 2 days back, which improved over a period of half an hour's time. And along with that, he noticed clumsiness of the left hand 1 day back. So this is a story, episodic paresthesia left side of the body. Then used to occur 3 to 4 times in the last 2 months. Now for the last 2 days, he has got weakness as well as numbness of the whole of the left upper limb. This is the examination. His pupils were normal. The ocular movements were normal. There is no field deficit. Nothing else in that part. Field testing is also normal. Ocular movements in all directions were normal. No facial elevation. Tongue movements normal.
മാക്സിമം ശരി വാ തുറന്നോ കണ്ണു തുറന്നോ ആന്ന് പറഞ്ഞേ ആന്ന് പറ ആ നാക്ക് നീട്ട് നാക്ക് അങ്ങോട്ടൂടെ തള്ളിക്ക് മതി മതി വെരി ഗുഡ് പല്ലി കടിച്ചേ മതി ഇനി മാസ്ക് ഇട്ടോ ഈ കുത്തുന്നത് ഒരേപോലെ അറിയാമല്ലോ വ്യത്യാസമില്ലല്ലോ ഇത് രണ്ടും കഴുത്ത് അങ്ങോട്ട് തള്ളി പിടിച്ചേ തള്ളി പിടിച്ചോണം ഇങ്ങോട്ട് തള്ളിക്ക് വളത്തോട്ട് മതി.
Come to the upper limbs, the bone was, there is no pronated catch, pronated was normal. There is some suggestion of the finger flexion. It is magic. There is some suggestion there. The third was normal. Biceps normal. Biceps normal. Now look carefully at the muscles of the left hand now. This section is normal on the right side. It's also normal on the left side. No, it was weak on the left side. So you check. Come to that again later. But the finger extents are markedly weak, mainly for the middle two fingers. Support is longest weak on the left side.
ശ്രമിച്ചാൽ മതി മോനെ എനിക്കറിയാം ബുദ്ധിമുട്ടുണ്ടെന്ന് എനിക്കറിയാം ട്രൈ ചെയ്താൽ മതി ഇനി വിരൽ മടക്ക്
Finger flex is normal on the right side.
ഇത് മടക്ക്
Weak, but about 4 to 4 plus power on the left.
പിടിച്ചോ മതി വിട്ടോ ഇനി തള്ളവിലറ്റം മടക്ക്
Support is longest is weak.
ഇത് കണ്ടോ ഇത് മടക്കിക്ക് പിടിച്ചോണ്ടി കണ്ടില്ലേ അതേപോലെ ധൃതി വെക്കണ്ട അയാൾ ധൃതി വെക്കാതെ ഇങ്ങനെ മടക്കിപ്പിടി ശ്രമിച്ചേ
That is weak.
പറ്റണില്ല പറ്റുന്നത് നിൽക്കുക ഇങ്ങനെ കൊണ്ടുപോവാ
Then his opponents was weak.
അറ്റം മടങ്ങ പിടിച്ചോണ്ടിരിക്കുക
But support is also weak on the left side.
ഇതകത്തോട്ട് പിടിക്കുക
That is weak.
അകത്തോട്ട് പിടി പറ്റണില്ല കുഴപ്പം അതേപോലെ ഈ വിരൽ പൊങ്ങണം
Abductor pollicis is longest, vertebralis is weak.
ഇനി വിരൽ ഇവിടെ വെച്ച് അകത്തി പിടിക്കുക അതേപോലെ
Crucial are all weak on the left side. But maximum weakness of finger extension.
അകന്നിരിക്കണം
Abductor digiti minimi and other intrusive.
ഇനി ഈ വിരല് മുകളിലോട്ട് ഇങ്ങനെ എടുത്തേ ഇത്
Support is longest weak.
പറ്റണില്ല ഇത് പറ്റണം
Markedly weak.
ഈ വിരല് പറ്റണില്ല ഇത് പിടിച്ചിട്ട്
This section is also weak. But maximum weakness of the finger extension.
പറ്റണില്ല
Abductor pollicis is also weak. Lower limb power normal. He is holding it to keep the chair, but very convinced about his participation. But gait did not show any spastic gait.
തളർന്ന് കിടക്കണേ
Sometimes it's old rigid, something beautification.
ഇതൊന്ന് പൊക്കിക്കേ വിട്ടോ ഇത് പൊക്ക്
No lower limb powers were normal.
ഇത് മടക്ക് ചവിട്ടി നൂർത്തേ അതേപോലെ ഇത് ചവിട്ടി നൂർത്തേ മതി നീ പാദം മുകളിലോട്ട് പിടി
This process is normal bilateral.
പൊക്കി പിടി
HL also
ചവിട്ടിക്കേ മതി മതി വിട്ടോ
abduction normal.
ഇനി
Now come to the reflexes. It's called generally bilaterally brisk reflexes. No gross asymmetry can be seen.
അത്ര മതി
Finger flex was absent bilaterally. abdominal reflex was intact. Brisk abdominal reflex bilateral. Knee jack bilaterally brisk, angle normal.
ബലം കൊടുക്കാം ബലം കൊടുക്കാം. നീട്ടി വെച്ച്
Plantar was indefinite. Okay. Then I think sensory system, in the interest of time, I'll skip that examination. But all examination, sensory examination was normal in both upper and lower, including I even checked the anesthesia, joint position, sense, everything was. I'll fast forward a little bit.
ഇതും ഉണ്ട് ഉണ്ട് ശരി ഞാനിതാ താത്ത്
The face was open.
താത്ത് ഓക്കെ ഓക്കെ ഇവിടെ അങ്ങോട്ട് നോക്കി മതി. ഇനി ഈ വിരലി പറയണം. താത്ത് ഓക്കെ
Again normal.
ഓക്കെ ഇത്രയും നമ്പർ.
What about cortical sensations, sir?
And that's graphosty. I was checking the just cortical sensation now. This is the one I was checking that I skipped that.
ഓക്കെ
Janssen also is a cortical sensation. The graphesthesia, I checked that's a normal.
ഇത്രയും നമ്പർ.
He said, he said. And this is the gate. Romberg's negative, gate normal. There is no spasticity. And the work is also. So that's on examination, visual acuity visual normal, caneless normal, motor query spasticity in the finger flexes, no pronator spasticity, weakness of finger extensions, extensor pollicis longus, finger flexes, flexor pollicis longus, but maximum 4 finger extensions, extensor pollicis longus, and abductor pollicis longus, and weakness of all small muscles of the left hand. DTR all brisk, abdominal reflex normally elicited, plantar flexor bilaterally, sensations all normal. So where is the localization now?
The right frontal lesion, mainly affecting the
Hand area.
hand area.
Okay. First of all, is it element or UML? That's the question.
Catch near a
It's a UML lesion, sir. It's the cervical cord.
It could be in the cervical cord, could be in the hemisphere, but the reflex are bilaterally brisk. Abdominal reflex is bilaterally.
But there is some dystonic posturing of the left, some patchy weakness of the left hand, which could indicate
right. Maximum weakness was in the middle two fingers, as well as the finger extensions.
It looks like a myelopathic hand.
The pattern of weakness is in there, so like a pyramidal weakness. Pattern of weakness.
Yeah, could be. That's correct. And there is some finger spasticity also that tells you that's more likely to be a pyramidal weakness. Okay.
Sir, checks for the dexterity, sir. Dexterity was checked, sir. Dexterity.
Yeah. So dexterity is the one which you have to look for, but I did not do that because already I got a finger. Can you? Okay. Now look at the. Always, very often we do not look for fingers. We stop with the pronator spasticity. Asmita, can you please mute that particular person who has got from where the voice is coming? Can you please stop? Asmita, can you mute the person?
Pankaj Rathi.
Eh?
Pankaj Rathi.
Okay. Now look at it. So very often we don't do finger spasticity. Look at this spasticity now. So pronator spasticity is good. See, you look very carefully. So that's the thing you have to. The way you have to do that. The finger will grip on your hand. So always do that. That tells you that it's got a spasticity is confined only to the distal muscles. Even the posterior muscles are not affected. Such a kind of an area confined only to the distal part is more like a cortical lesion rather than a cord lesion. But both possible you have to keep in mind. So was it a cord lesion or a brain lesion? That's the question. What investigation you need now? Brain?
MRA cervical cord.
Okay.
Normal.
The cervical cord. Sagittal cut is normal. This is the coronal cut. And this is due to axial.
Qualify for a
Pardon?
Does this qualify for a myelopathic hand? Dasri Srinivasan was telling this could be myelopathic hand. It's unlikely, no?
No, the myelopathic hand also, the first thing will be, this can fit in with that. The first thing will be a finger, the little finger will go in the abducted position. The lateral two, the palmar index will be the weak, so medial will be weak first. Then comes those fingers will drop down. The thumb, etc., will not be affected. Thumb index will not. Here, the thumb is affected maximally. The abductor flexor pollicis longus and abductor pollicis also affected equally as the finger extensors. That's not so. That is not like a myelopathic hand. Myelopathic hand, classically, the medial will be maximally affected. So the cervical spine is normal. See, what is against cord lesion? There's another point favoring again is that such a severe weakness of the left hand, sparing the sensation, is also out for a cord lesion. We expect either some posterior column involvement in the left hand or a parathalamic loss on the opposite side. We expect with such a severe weakness due to cord lesion. Again, that's a point again. So what else you need now?
Sir, 1 minute, sir. Excuse me.
Yes.
What is the first point, sir, against cord lesion? First point.
He's got a finger flexion spasticity.
Okay, sir. Okay, sir.
Only confined to that area without affecting the pronator spasticity.
Okay, sir.
It's only confined to a focal area. That means more likely to be a cortical rather than a lesion confined to say C6, C5, C6 or above C5. But it's only that much of degree of this thing. That's one point. Secondly, a cord lesion of that kind should have produced some sensory impairment as well. But cortical lesions, as you are well known, maybe only pure motor will be there. When you get a pure motor focal weakness, keep the cortical lesions one possible site of lesion.
Okay, sir.
So, Joy wanted MRI. MRI was taken. The diffusion shows in part that this is the ADC map. This is the
MRI not seen, sir.
MRI not seen?
Yeah, we can see, sir.
We can see, sir.
MRI seen.
Yeah. Joy, are you able to see now?
Then I'll leave and come back.
You cannot see it, Umar, you cannot see?
Yeah, we can see, sir.
We can see. It shows the diffusion restriction.
See, sir.
We can see, sir. Clearly seen. It is seen, sir. It is seen.
Okay. Right. This is the T2 weighted, so you can impart on the same area.
Dissection of the right-sided artery, sir.
I'll show that MRI is coming. That's in part of the flyer. This is the SWI. This is that source image of the MRI angiogram. No intracranial block can be seen. nor any dissection in the extracanal segments. This is endocrine vessels. Okay, so vascular imaging is normal, and you find infarct in a person is only young age, 23 or 24-year-old.
Echocardiography.
Pardon?
Sir,
Echocardiography.
vascular is normal, sir. Can you show the MRI angio again?
MRI, I'll show the MRI angio once again.
Was the MRI normal?
Normal, no. MRI angio is normal.
Sir,
MRI is
right ICA. Sir, right ICA.
Here, no? That very often can be seen the corner segment. This kind of a narrowing can be seen normally. It's an artifact. Artificial, this can be very often can be seen normally. There is some suggestion of a narrowing.
So then the neck carotid. Dissection in the neck arteries.
Neck carotid, I have not shown that, but that angioedema I have not shown, that is normal. It was taken, that is normal. So what are the investigations you need now?
Echo.
Cardiac evaluation.
MRI of the neck vessels and echo.
MRI of the neck vessels was taken normal. I did not
Echo,
show.
sir, it looks like an
Echo
embolic.
cardiogram to rule out
Cardiac work
thrombus.
is perfectly normal. Let's see the blood work now. Cholesterol was 358. Then renal function, urea 55, creatinine 1.2. Any other test you want? Cardiac workup normal.
Echocardiography?
Yeah, normally a cardiology consultation was taken to
Sir,
echocardiography.
CT angio.
Thrombophilia workup.
Homocysteine.
Thrombophilia.
Homocysteine.
Correct. Homocysteine thrombophilia. Prothrombotic states. Okay, let us see. Before that, don't you think vasculitis is a possibility you have to keep in mind? Okay, let us see. Yeah. So urine protein was 115. And the INF screening was positive 3.2. Double standard antibody was positive. With 70 as opposed to less than 25.
He had elevated liver enzymes, no?
Yeah, mildly elevated liver enzymes. And the anti-DS DNA is strongly positive. Then in a renal biopsy, which showed focal segmental glomerular sclerosis, NOS with moderate global glomerular sclerosis. I don't know all these things. Anyway, PL2 and study is advised. The PL2 receptor antibody was negative. Don't ask me what is these things. Anyway, he has got renal involvement as well. This is the cardiac echocardiogram, which is normal. So it's a SLE with CNS vasculitis. So I'm seeing in a male person of young age, SLE occurring in this age, I'm seeing for the first time.
What was the antiphospholipid antibody?
The antiphospholipid antibody, I do not remember whether done or not. It should have been done being an SLE patient, because this patient came to me from the nephrology department because of the hand weakness. So it's already a diagnosed case of SLE. They must have an APL antibody. I do not remember that value. Because I did not do that. Because these results are all already done prior to coming to my department. The patient came to this investigation was done earlier. It's known case of SLE.
Do they respond to pulse steroids?
Yeah, they give the pulse steroid, and then I give the pulse steroid and improved and put on antiplatelet. It's on high dose steroid now. And not only steroid, is also put on azathioprine.
It's a proved SLE with proven renal involvement. What is the role for APL antibody?
Which antibody?
APL antiphospholipid antibody.
Yeah,
no
SLE can be associated with APL antibody. No, that's the reason.
No, we have to start on anticoagulation. Sir.
Yes, lifelong anticoagulation.
Yeah. If APL is positive, you need lifelong anticoagulation.
How old is he, sir?
He's only 23 or 24.
27, sir.
27, yeah. Okay. There's nothing challenging in that, but certainly it is unusual in this boy. I did not suspect it's necessarily. Now, this is a story of a 21-year-old man. He presented with repeated blinking of his eyes, which he said he cannot control. Just been there for the last 3 weeks. No other complaint. But this case was shown to me by Dr. Sinju. Which is that he was continuously blinking.
മുകളിലോട്ട് നോക്കിക്കേ.
Ocular movements no.
താഴെ നോക്ക്. ഇങ്ങോട്ട് നോക്കിക്കേ. ഇങ്ങോട്ട് നോക്ക്. ശരി, ഞാൻ പറഞ്ഞാൽ ഒരു കണ്ണടയ്ക്ക്. 2 കണ്ണും അടച്ചോ. അടച്ചു പിടിച്ചോണ്ടേയിരിക്കണം കേട്ടോ.
Close the eyes till it continues.
ഇനി കണ്ണ് തുറന്നേ, മുകളിലോട്ട് നോക്കിക്കൊണ്ടേയിരുന്നേ.
Looking up.
ഇനി താഴോട്ട് നോക്കിക്കേ. ഇവിടെ നോക്കാം. ഇവിടെ പല്ലി അണിച്ച് നാക്ക് നീട്ടിക്കേ. എന്നിട്ട് മുകളിലോട്ട് നോക്കുമ്പോൾ താഴെ നോക്കിക്കോ. താഴോട്ട്, മുകളിലോട്ട്, വലത്തോട്ട്, ഇടത്തോട്ട്. ഓക്കെ, മതി.
So on examination, almost continuous blinking of eyes, no contraction of the orbicularis oculi. That's what the same as examination. So what do you think the diagnosis possibility is?
So either blepharochronus or functional.
Okay.
Functional maybe, sir.
Functional, sir.
Looks like functional.
Everyone thinks functional. Okay, very good. I also thought functional.
No, looks like non-organic only, sir.
Non-organic.
And can it be tick or no, sorry?
No tick. This will be rhythmically going on like that.
Can it be blepharochronus?
Yeah, but that also mimics like that, but the situation is only 2 weeks, no other condition, only having this one. So we had one possibility is a blepharochronus, the other possibility is in fact, by definition, is a blepharospasm. Increased blink rate is the earliest phenomenon, so by definition, is a blepharospasm. So that it can be organic.
So how is it different from blepharochronus?
Blepharochronus and blepharospasm is almost same, except that the chronus part, the blepharospasm will be contraction of the orbicularis oculi, contracting it. In blepharochronus, it is something like a repeated blinking, like this.
So this is blepharochronus or blepharospasm?
Yeah, it's more like a blepharochronus only. But if
suppressible, sir?
Pardon?
Is this suppressible? Can the boy voluntarily suppress this?
No, he said he cannot.
He can voluntarily do that, not suppress.
Pardon?
He can go on doing this. I think even on closing, this continues, sir.
Okay, let us see. So what I did was I wanted to try the technique of diverting the attention to find out whether it can subside or not. See, so what I did was ask him to alternatively divert his attention to finger like this. Allow him to have a time to think about it. What is feel like. So what do you think? My technique did not work or diverting attention. He continued to have this kind of a blinking even after diverting his attention.
Entrainment.
Pardon?
Entrainment.
Entrainment for the doses is not possible. Entrainment is only for one tremor confined to one hand. You can do it with the other hand.
But the frequency is reduced now, sir, with attention diversion.
Yeah, slightly reduced also. I cannot totally suppress.
Sir, here there is no eyeball involvement to suggest any obsoclonus obscuria. It looks like so most likely something like either a non-organic or a blepharospasm, sir.
Okay. So then.
Sir, any dryness of the eyes?
Pardon?
Any dryness of the eyes? Dryness.
No dryness. No dryness. No pain, no dryness of the eye.
You have to try another attention diversion maneuvers.
Okay, very good. So what did I do is I did something else, another technique, which I used to do while I was at Kottayam Medical College. Now I am little hesitant to do that. So I took him to the EMG lab and told him that his nerves can be set all right by shock therapy and be all right by the time the shock is over, and give some suggestion. So I put the electrode there.
കണ്ണടച്ചോ താഴോട്ട് നോക്കുമ്പോനെ കണ്ണത് മുറുക്കി അടക്കി വിട്ടോ 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 അപ്പോഴത്തേക്ക് ഇത് മാറും. ഞരമ്പിൽ മാറിക്കിടക്കുന്ന ശരിയാക്കി ഇടാൻ വേണ്ടിയിട്ടാ ഷോക്ക് അടിച്ചൊന്ന് പ്രോബ്ലപ്പെടണ്ട. കണ്ണടപ്പം നിൽക്കുവോ അപ്പോൾ കേട്ടോ.
For the people who couldn't understand Malayalam, I was telling him that I'm going to give you some. The nerves are in a disarray. I am going to set it all right by giving shock. By the time shock is over, his eye will over. Okay, that's what I was telling. Then I started giving stimulate the patient. Then increase the current of what required for me. Then give the suggestion that will subside.
അല്ല ഇത് കുറച്ച് 300 അടിച്ചാൽ 1 കുറച്ച് കുറഞ്ഞു കേട്ടോ. ഇനി കണ്ടിച്ചോ കുറഞ്ഞില്ലേ? നിക്ക് അടിക്കാതെ കുറഞ്ഞു കുറഞ്ഞില്ലേ? കുറഞ്ഞു ഇപ്പൊ കുറഞ്ഞു. 2 മിനിറ്റോടെ ഇരിക്കട്ടെ, അത് കുറഞ്ഞു വരും. ഇനി ഒന്നും അടിക്കാൻ.
This is 3 minutes later. This is the patient.
ഇവിടേക്ക് കംപ്ലീറ്റ് മാറും. 2 ദിവസം കൊണ്ട് പൂർണ്ണമായിട്ട് മാറിക്കണം. പക്ഷേ
I don't know whether it's ethical to do that or not. Some people say that it's not correct to give a false, impression like that. I do not know.
I think it's the right method. That's for the Westerners. Westerners have some strange ideas about ethics. So I think that can be done.
The problem is now we know that surely that it is functional. We can send him safely with whatever drug you have. Otherwise, we are always in a worry whether are we dealing with a clonus or something like some other condition may develop later on. Now we can be very comfortable. There is nothing organic is there. We need not undergo an MRI and things like that. Okay, that's only a short case. Now go to another one. This is a story of...
So one doubt, sir.
Yeah, please.
So any difference between blepharospasm and blepharospasm? I didn't hear that word.
That's in fact, Joy asked that question. See, in fact, totally it will be difficult to differentiate. In blepharospasm, there is a dystonic contraction of the palpable endem, either the orbicularis oculi total or at the palpable part of the orbicularis oculi. Orbicularis oculi is a 2 part, orbital part and palpable part. If the orbital part is also affected, whole orbital is affected, in blepharospasm due to that, the eyebrow will come down like this. It will come down, remain for some time and come. It's a dystonic contraction. It will come and go like that. So in the case of dystonia confined to the palpable part, only there will be mimicking an apraxia of eyelid opening, just like we saw some day back. I showed you that one case. The patient closes, you will not be able to open because of the dystonic contraction of the palpable part. So here, it's a clonus. There is no persistent contraction. There is no sustained contraction. Dystonia, by definition, should be a sustained contraction, which is not there in this patient. So ideally, it should be called as a blepharoclonus rather than a blepharospasm. But by definition, some people say whenever the blink rate is more, you call it as a blepharospasm, like more than 18 per minute. That is a cutoff value. But actually, this should be called as a blepharoclonus rather than a blepharospasm if it is organic. Because by spasm, I mean, should be sustained for a period of time. It's not sustained. It comes and it's like a blink only. Am I clear?
Thank you, sir.
Okay.
Yes, sir. Thank you.
This 52-year-old lady, history of imbalance while walking for the last 15 years. The imbalance is more at night. History of loosening or chappals from both feet. History of paresthesia both legs for the last 10 years. And patient give another interesting story. Her legs will get lifted up on their own while sitting, or even while walking, sometimes the feet will get lifted up, which made her fall few times. So it's something like a sensory ataxia, but also give this particular funny complaint. Let us see this lady now. So there's no nystagmus. There is no saccades well.
എടുത്തോട്ട് നോക്കുമ്പോൾ പെട്ടെന്ന് എടുത്തോട്ട് നോക്ക്, ഇവിടെ നോക്ക്, വലത്തോട്ട്, എടുത്തോട്ട്, താഴെ നോക്ക്, മുകളിൽ നോക്ക്, വലത്തോട്ട്, ഇടത്തോട്ട്, ഇങ്ങനെ പൊക്കി പിടിച്ചോ, ഇങ്ങനെ പിടിച്ചോ, ഇങ്ങനെ പിടിച്ചോ.
Upper limb, there is no pseudothetosis. Bone power normal in the upper limb.
മുറുക്കി പിടി, മതി വിട്ടോ, കൈ ഇങ്ങനെ പൊക്ക്. അമ്മേൻ്റെ വിരലേ തൊട്ട് മൂക്കി തൊട്ടേ.
There is no incoordination. Lower limb power is normal.
പാദം മുകളിലോട്ട് എടുത്തോ, മുകളിലോട്ട് എടുക്ക്, തള്ളവരുടെ പൊക്കി പിടിക്ക്, മുകളിലോട്ട് പൊക്കിക്കാൻ മതി.
All reflexes were absent. Knee jacks are absent, ankle jacks are also absent.
ഒരേപോലെ അറിയാവോ?
Tension pain by normal. The low.
ഒരേപോലെയാണല്ലോ. ഞാൻ തൊടും.
He said she is able to feel the touch sensation. The vibration is impaired. It is over the knee. But absent over the ankle and toes. He made one mistake in the. It's impaired in the upper limb. But the lower limb is grossly impaired. You do not know the position of the movement as well. Then this is the gait of the patient. You get osteoarthritis of the knee also. That's why the knee goes into hyperextension. Yes, severe posterior operative. The moment it closes, even the wide apart feet, the moment closes the eyes, she falls. No, she's sitting. Look at the legs now, both the legs. Both on her own, on its own. No, she's not doing it voluntarily. Goes involuntarily, goes up sometime. It doesn't hit the other foot. Now, so look at the feet to find out whether it's present or it's still present. Even looking at the feet, this moment she could not control. He asked her to look at the feet. It's not modified by eye closure.
കാലിലോട്ട് നോക്കിക്കേ.
Ask it to look at the feet till it goes out.
കാലായിക്കൊണ്ടിരിക്കുന്നത് അല്ലേ?
So Heimelberg normal, Ehlers normal, motor tone power normal, no finger nose incoordination, no pseudothetosis. Lower limb tone power normal, detail absent in both upper and lower limb. Sensations, upper limb, there's impaired joint sense, I forgot to write that. Lower limb touch pain normal, impaired vibration joint JPS over the toes. Rhomboids markedly positive, severe sensory ataxia. There are spontaneous movements of both feet in the form of twisting movements or slow deviation of the feet. Sometimes the legs get dictated by themselves without their knowledge. These movements are not affected by eye closure.
But tendon reflexes?
Tendon reflexes are all absent. So what do you think the state of lesion and possible diagnosis?
Sensory ataxic neuropathy, probably ganglionopathy.
Okay.
Probably paraneoplasty.
This has been there for last 10 years, 10, 15 years.
And sensory attacks in neuropathy is high on the list. Whether what is the cause, we have to find out.
What is causing the abdominal pain?
That could be, I felt something like a pseudoarthritis of the toes, something like.
Is it arthritosis or dystonia, or is it pseudo or true? Because pseudo is not. Because pseudoarthritis means it's present only in eye closure.
Yeah. So it is so marked, the posterior column, I mean the sensory root involvement, posterior root involvement is so marked that this goes into some sort of attitude or some abnormal movements.
Okay.
Is it painful moving toes or peripheral neuropathy?
No, there is no pain at all in this patient.
Could be painless legs moving toes, but usually only the toes will move.
Okay, the only toes. So this also whole limb will, this will move. It's again not typical of a painful limbs and moving to. That's a rhythmic writing type of movement going on like that. This is not like that. Episodically goes into, sometimes goes away and goes to the opposite side also, and then hit the opposite leg. Sometimes twisted by itself, sometimes may fall. That kind of a painless moving toes and all, they will not make the patient fall.
Any possibility of myoclonus, sir?
No myoclonus, no myoclonus.
Pseudoarthrosis?
Be more like a severe pseudoarthrosis, which is not corrected by looking at it.
Very good, very good. So as Umar said, it is not pseudo, we can't call pseudo, true arthritosis and dystonia also. There is dystonic contraction also, arthritosis, dystonia also. Okay, so what do you want now? In CS?
Nerve conduction, yeah.
Nerve conduction, motor conduction, normal, sensory conduction. Snaps absent in the lower limb and upper limb. In the lower limb. Parameters, ANA profile, H1, A1C normal. So what is your diagnosis? Now this is the typical prototype of ataxic neuropathy. So the thing is, yeah, we are, in Kottayam, Umar was also part of that article which is published.
Yes.
Get these persons with a severe ataxia, which is out of proportion to the sensory loss. That's the point of, that's why it's called ataxic neuropathy. In diabetic ataxic neuropathy, we don't call, because that much of attack, even the severe sensory loss, the diabetes, they won't be ataxic. But these patients, their touch is normal, pain is normal, but attack is out of proportion. So this kind of involuntary movement is very common in severe sensory ataxia. I have seen badly subtle, believe me, ballistic movements of the lower limb with sensory attacks in tropical ataxic neuropathy patients. So this is actually not a true pseudo-arthritis, it's a true arthritis and true dystonia.
Pseudo is a word, sir. Why should we pseudo?
The pseudo-arthritis is called because it is present only on closing the eyes. There's something like a flapping tremor is occurring like that. That's called pseudoathetosis. If it is present even with open eyes, there is no pseudo in that. It's true athetosis. Now, there's a similar problem in this patient. The story of a 7-year-old man. His complaint started as pain in the left shoulder 1 month prior to admission. This was followed by numbness in the left hand, which gradually ascended over the left forearm in 1 week's time. In another week's time, the numbness spread over the left half of the body. For the next 10 days, the patient noticed difficulty in walking in the form of unsteadiness of gait and also clumsiness in the left. So, precipitated in micturition for the last 5 days. So, pain in the left shoulder 1 month, then followed by numbness of the left hand, which gradually ascended over the left forearm, then entered the left half of the body. For the last 10 days, patient noticed difficulty in walking in the form of unsteadiness. So, this is the position. Look at the hand of the patient. Ask him to keep the hand like that. He's looking at the hand. See what is happening to the hand. By closing, it becomes more. It becomes a distorting posture. Hand goes on its own. Forwards, no, biceps, biceps. It's just the smile weakness of the hand, but we cannot be certain because some of them could be due to
കയ്യിലോട്ട് നോക്കി കയ്യിലോട്ട് നോക്കി അങ്ങ് പിടിച്ചോ നോക്കി പിടിച്ചോണ്ടേ കയ്യിലോട്ട് നോക്കി കാണേ.
Look at the thumb, it goes into adducted position. Even looking at the hand, it goes into abnormal position. Look at the thumb and it gets distorting position is occurring in the left. See the hand is coming down. Goes and hit the opposite hand. Without this. Examination.
ബലം കൊടുക്കണ്ട അവിടെ വെച്ചെന്നാ മതി.
The left hand goes up, left is lifted up on its own. It's levitated up. Reflex the upper limbs were diminished bilaterally. But biceps was on the right. Left upper limb more reflex were diminished. Biceps supinate and right. Impression also absent of the knee and jungle injection of this more on the left side. Sensation, severe impairment of processing.
കാര്യമാണോ മുകളിലാണ് കണ്ണടച്ചോ ഇപ്പൊ
On the left hand. Okay, on examination, painless normal, motor, tone normal, power, left upper limb, left deltoid, triceps muscles, 8-4 plus. Asmita, is there any way to mute that particular person, please? Left finger sensates flexes small muscle left hand grade 3 plus. Right upper limb normal. Lower limb grade 5 both lower limbs. Here left upper limb all absent. Right upper limb isopinated 1 plus. Triceps present. Lower limb brisk bilaterally. Left upgoing. Right downgoing. Sensation impaired vibration joints in both hands. So, what is your diagnosis now?
Is he diabetic, sir?
Not a diabetic.
There is a sensory joint positions are severely affected in this patient.
The upper limb bilaterally more on the left upper limb. Lower limb normal.
Sir, cortical senses. Cortical senses.
Cortical, it's
More
like,
like
I don't
it is
know.
due to cervical myelopathy or something. Sir.
Okay.
Column involved.
The upper limb are all absent.
So this cervical cord related dystonia involving left upper limb.
No, what cervical cord mean? Where is the site?
Site is above C5, sir. Above C5.
But why reflexes are all absent in this patient?
Not above C5. It could be 5, 6, 7 myeloradiculopathy.
Sir,
Yeah.
about T1, C5, C6, C7 radiculopathy.
Myeloradiculopathy.
From myelopathy and radiculopathy, agreed.
Yeah.
But
Yeah, multiple roads affected, or maybe antihound cell is possible, but there is no wasting. So
whenever
it could be part of,
when you got C5 to D1, reflex is lost.
yeah.
So extramedullary compression, do you think that kind of degree of efficiency of reflex loss?
Very unlikely. Could you have to think of a intramedullary lesion?
Whenever you get extensive reflex loss, I think this point I mentioned last time. No, when you get somebody was asking whether how can you explain that reflex preservation with anterior cell loss. So initially I was mentioning that about more than 50% anterior cell should be lost to produce a clinically significant weakness. But reflex loss can occur early in posterior root or intramedullary lesions. Okay, so intramedullary lesions is a good possibility, but how to explain the preserved pain but impaired posterior column? Intramedullary affected dissociative anesthesia.
Ganglion can produce a difference, sir. Ganglion involvement can produce a differential involvement.
But there's a gangliopathy. That we should put peripheral signs then. Gangliopathy agreed.
It's more like extradural compression because posterior column is involved more, and there could be multiple discs which.
Yeah, that's a possibility. But yeah, right.
For the reflex loss, along with the pain and temperature should at least temperature should
get involved, right? But the classical teaching of intramedullary lesion is what this is because the lesion is starting in near the central canal. Okay. It expands it, the first affects the crossing fibers, produce dissociative anesthesia, then reflex loss, then anterior cell loss. Like that it goes. But that does not mean that intramedullary lesion should always start in the center. Suppose a lesion is affecting near the posterior column, then can it not produce similar finding? A lesion which is extending downward. Why the intramedullary lesion is extending downward vertically logically is because always the tumor or lesion grows in the line of least resistance. So when the tracts are oriented longitudinally, the tumor grows along the tract. So they go up and down. Whereas extramedullary compression go horizontally. So they try to compress from one side and compress the cord. That did not go longitudinally along the side of the cord. So that is the peculiar why the tumor lesion behaves differently in intramedullary lesion as well as extramedullary. Intramedullary they go longitudinally. You can even the first case report of intramedullary tumor was extending from C1 to conus without any expansive this thing, longitudinally going like that. But extramedullary compression will not give like that.
But the posterior column involvement usually doesn't affect the reflexes now.
It will not affect, but the lesion if the lesion happens to be in the intramedullary location, the reflex fibers are also going to the side. Imagine a lesion near the posterior column, and just anteriorly the reflex fibers are coming. It can refer to the reflex loss, not touching the anterior console, producing wasting and all. Okay, that can produce this kind of phenomenon. So, but that will not be seen as syringomania-like presentation, usually intramedullary tumors. Okay, let us see what you want now. This is what the patient had. It's got intramedullary, also the axial cut. It is affecting, in fact, posterior, not only posterior coming anteriorly, but the main bulk was in the posterior.
That's a syringe, sir.
There is a tumor.
More white thing.
Then this is the contrast study. What is this irregular contrast enhancement seen here? This is the contrast. These are all contrast. The plus C indicates contrast. Plus C means contrast. This is a T2 weighted sequence. T2 hyperintense. This is the T1 with contrast. This again showing the sagittal cut.
What could be the cause of the atetosis here in this case?
So all of you have said, no, that's exactly correct. It should be the posterior column sensory loss. It's got severe posterior column sensory loss, which can result in the atetosis to a severe, when it becomes severe, can be a true atetosis, can be a true dystonia, can produce arm levitation. See, his hand is going up on its own because he has total loss of proprioception on the left hand. So this, in fact, probably sometime back, the atetosis dystonia in syringomelia have published also. This can occur. So the sensory loss of severe degree, especially proprioception loss, can result in dystonia, atetosis, and balism.
This is a tumor.
There's a tumor. Histopathology is operated and found to be a tumor.
Did he improve?
Follow-up, I don't know. Because when the patient goes to surgeon, then subsequently the follow-up is with them. Okay, shall we stop? Yeah, please. Yeah.
So one doubt,
Sir,
it's a
upper
lady
cervical cord. Upper cervical cord lesion.
Yeah.
They will do surgery for this, sir. It will be hugely mutilating.
No. What is they do surgery for a biopsy? We want to know what the nature of the lesion is. No, so they can do it. They put a medial through they go through the median fissure, posterior median fissure, and they take a biopsy from. They can do that.
Okay, sir. Thank you.
So the lady with the sorry, sir.
Yeah, please.
Sir, the lady with the unilateral left lower limb atetosis, can we call it a restless syndrome, sir?
No,
unilateral leg.
No, restless is mentally different. There, the patient does not have any kind of a deficit, posterior sensory loss, or this will not be there. They got a creepy abnormal sensation, and they are otherwise normal. The PLM can be associated, periodic leg movements can be associated with that, and they can move the leg voluntarily to avoid the uncomfortable sensation. So whatever movement they demonstrate is voluntary to provide to get relief of this uncomfortable sensation in RLS. Here, this movement is occurring spontaneously without a knowledge. So that's not an RLS.
Hi, sir. Good evening. Sir, this is Sunil Narayan from Jipma. I tuned in a little late, actually, because there was some other work going on. I had to finish it, and then I
I never
this mail.
You are attending these programs.
No, I just joined now, actually, because since it's your program, I thought that definitely there will be something interesting. Okay. So a very nice illustration of how the peripheral lesions, how they can produce atetosis and dystonia due to sensory deprivation. it's the same principle as pseudoathetosis we see in peripheral neuropathy.
Correct.
So yeah, I just wanted to. I was just intrigued by you are adding that balismus also to that. How does that? How do you explain?
In fact, no, because Cyril, in fact, I was collecting about Umar will know about nearly 30-40 patients of TA and tropical neuropathy in central Travancore. And one patient was surprisingly fine that it's throwing about. The lying down is just like throwing ballistic like a movement. It's only an accelerated form of this kind of arm levity. You know what happened if you see the leg? It's also jerking. No, for the first lady, the patient was jerking and go to the hitting the other things. It may be an exaggerated form, means it is mimicking.
It could be a kind of the ascending spinocerebellar tracts also may be making. So some kind of a dysmetria happens and they make some additional, they are not able to exactly gauge how much of the power has to be generated to make a certain degree of movement. So, I mean, that could, I mean, maybe that is, I mean, I'm just thinking. That could be,
that thing, what is happening is then spinocerebellar tract is affected, it becomes an ataxic limb. The involuntary movements is due to the loss of proprioceptive input. That is an involuntary movement.
Yeah. So this movement, what we find as balismus, if it is, it depends whether voluntary or involuntary. If it is completely involuntary, then I think we have to explain only as balismus. But if there is a voluntary component which becomes uncontrolled and goes beyond, okay, fine. Then it has to be.
Yeah, it is totally
then the mechanism is be right. Okay, fine.
The peripheral navigation can produce dystonia also.
Yeah, it can produce dystonia.
Yes, that is described actually.
Any condition producing severe proprioceptive loss. That is what is happening in peripheral. Topically attached neuropathy, the pathology is in the peripheral nerve. That is the first patient. The second patient had a lesion in the posterior column. Only thing is
normal posturing does need continuous efferent inputs also from the muscle spindles and Golgi tendons, and also when that is affected, you can have kind of this posture.
Let's say the posturing extent cannot be maintained properly. That is, they get this arm levitation also.
Sir, one doubt, sir.
Yeah, please.
Sir, from your case, it is evident that athetosis as well as pseudoathetosis can occur with the sensory deafferentation.
Correct.
So the pseudoathetosis, the differentiation between the clinically whether it is athetosis versus pseudoathetosis is that when you close the eyes, it becomes worse, means it is pseudoathetosis.
Correct.
Is it like that, sir?
Correct. That is, we call pseudoathetosis only because when the patient is not looking at it. That is when the vision, because there's no compensation with the, just like a rhombogism.
Yes, sir.
Is nothing like a rhombogism of the hand. Okay. Right. But nowadays the term athetosis itself is taken away. Nobody uses the term athetosis. All these are all dystonic contractions. What we observe.
Okay.
Sir, was B12 done for that elderly man?
That elderly man was not done. Already we found a lesion there. And that's not suggestive of a B12 deficiency. There is irregular. You can see did you see the enhancement pattern? See the regular enhancement you can see here like that. But it's like what you see in a glioma, one area is more typically irregular enhancement. And it's asymmetrical also, affecting only hand severely. So all points are not favoring a B12 deficiency. Okay, is there time for one more case or can stop?
There one short case.
One short case. Okay. This is a story of a 60-year-old man. It's a very short case. Person with the history of slurring of speech as well as 2 episodes of fall backward for the last 3 months. So look at this patient.
ഇടത്തോട്ട് താഴെ നോക്ക് മുകളിൽ താഴെ നോക്കി മുകളിൽ താഴെ മുകളിൽ ഇങ്ങോട്ട് വലത്തോട്ട് ഇടത്തോട്ട്. Okay. Now next part is more power or normal abnormal finding. Gives the gait to the patient. Okay. Then this is the full test. Is positive. So what is the diagnosis?
Sir, history, what more? Just history.
History, I'll tell the history one. It's nothing but slurring of the speech as well as 2 episodes of fall backward for the last 3 months.
PSP.
Okay, PSP. Very good.
PSP.
Okay, everyone PSP. Now I'll tell you what this is one sign which I've observed in many patients of PSP, which is not described in the textbook. So I put a name for that sign. I'll show the sign once again. I'll show you one sign. This is a sign. Look at the eye, which I called it as eye on the sailing sign. It's going to get up. Now look at the eye. I looks at the ceiling. It will not come down. So when you asked him to look down, he was doing all the saccading movements. Okay, mildly slowing is there. But when you ask him to get up from lying down position, he look at the eyes are looking still at the ceiling.
That's doll's eye, yeah?
Doll's eye movement will be perfectly normal in PSP, in early PSP. Till last
Like, is it because of doll's eye that
yeah, exactly.
eyes are moving?
Down gaze palsy.
Yes, no created. See, grounded case is only minimal. I'll show that it is there. Can call it there. I'll show you the down gaze. Say, വലത്തോട്ട് നോക്ക്, വലത്തോട്ട് എടുത്ത് നോക്കച്ചാ, എടുത്തോട്ട് ഇവിടെ, എടുത്തോട്ട് താഴെ നോക്ക്, മുകളിൽ താഴെ നോക്കി, മുകളിൽ താഴെ മുകളിൽ ഇങ്ങോട്ട് വലത്തോട്ട് ഇടത്തോട്ട്. Okay, so this is, I do not know what this sign I observed, so I postulated just like Joy was telling. This is what this is, the eyes on the ceiling sign. You won't find in the textbook, there you don't search the literature, this sign will not be there. This is the MRI of the patient showing the classical morning glory sign. And this is a pathophysical mechanism which I thought the aspiration phenomenon may be due to combination of many factors like defective downward saccade, nuchal dystonia in the wake of intact ocular cavity. That is the point. His ocular cavity reflex is superb. That is why even trying to get up, the eyes can be shifted from the ceiling and contributed by his nuchal dystonia. That's why the eyes remaining like that. That is my postulate. I don't know if it's correct or wrong. May have been responsible for being able to shift their case from the ceiling. Do you agree with my explanation? Have anyone of you seen this kind of a phenomenon? Next PSP, look at this thing. You will find this. PSP.
It's a very good sign, sir. I think we should make this viral.
Yeah, and it should have your name also.
Yes. Yes. Okay.
Yeah, I think people come up with many signs which are much less striking. So definitely it's spreading as a teaching message. So yeah, it will be good if can send it for a this one to neurology or something as a, I don't know what is the mechanism to get a name. Once you publish on your name, ultimately it will be known by your name.
The thing
Sir,
is,
sir, we should have more such cases. I know we should have in other PSP cases also. We also will watch. We'll also will observe and we'll update you.
You just see the patient, next patient. It will be there. Definitely, it will be there. I am very sure about it.
Because I am saying that for last two, 3 years, I have been saying this sign, and teacher and student also, this is one sign you look for. So this case, I thought I'll show it.
No,
I think
you have
probably was,
hundreds of signs, sir. You have hundreds of signs, but at least we'll start with this.
Okay.
Yeah.
yeah, I think it will be become more easily appreciated by everybody once you show it in more than one person with PSP.
Yeah.
So 2 different phases or 3 different phases with the same thing, then it gets fully established. So that way, yeah.
If you just watch the video, definitely, I'm sure that you'll all see these things in your page.
Yes.
Okay, then. So, shall we close?
Okay, sir. Good night. Thank you. Thank you very much.
Good night, sir.
Thank you for the
Good night, sir.
100th
Thank you,
class.
sir.
Today was
Today is the 100th session. Thank you all for making it 100.
Centenary celebration.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, sir.
Nice.
So that was a nice dinner and very nice to see you, face to see your face and actually.
Thank
Bye,
you.
sir. Good night. Yeah.
Sir, this is Rupa.
Good night,
I
all.
just wanted to
Tell
ask
me,
you.
Ruba. Tell me,
Sir,
yeah.
this tropical ataxic neuropathy in that lady, sir, did you find any cause for it?
No, in fact, we have investigated everything. Here, vitamin levels in the, we found a cause that we estimated the arsenic, in fact, that I presented in that IAN guest lecture, that IAN oration. This is, I showed this study. In fact, what we found that central traveled area, the main diet was tapioca. So I did not know, I was wondering whether that can be related to that. So I searched, and then literature found that in Nigeria and the many other countries, the staple diet was cassava. Those people, cassava. So those people are also got Osungutan has published a lot of series on tropical ataxic neuropathy. This came later on. So I then found that this cassava in the West in Africa and our tapioca in Kerala are exactly the same.
Oh, okay.
Okay. In fact, the idea was given to me by my wife only, because we find if you look at the tapioca leaves, the cows will not touch the tapioca leaf. It will eat all leaves except for the tapioca leaf. So that means there's some poison in there.
Cows will not eat tapioca.
Okay, tapioca, they will not eat the tapioca leaves. And secondly, another thing is that there was on Givergis, sir, he published a lot of pancreatic diabetes due to calcification of the pancreatitis. And he postulated that it is also due to the arsenic content of the tapioca. So what I did was that in these patients, I did Umar was also part of the study, Umar and as well as Murali. So we took the nerve biopsy from these patients, as well as control patients from the persons who died due to accidents, road accidents. They get biopsied. They come to the postmortem, then they do the nerve, took a nerve from them, and then sent for arsenic levels to the central chemical laboratory in Trivandrum. We found that high arsenic content in not only in the nerve but also urine of these patients. So so there is some correlation with the arsenic content, but why it is occurring on certain people? But tapioca is a staple diet for many people. Not all of them develop these things. So there may be some genetic or some other factors which also contribute to the development of neurological deficit in such patients.
So it's arsenic toxicity, sir?
We can't call it arsenic toxicity in susceptible individual.
Susceptibility.
Yeah.
The body is not able to excrete the arsenic and keeps it in the body.
Right.
So the other cause of tropical ataxic neuropathy, again, diagnosed along with in the endemic areas, is in some population, along with the TSP, TAN is also seen. Tropical spastic paraplegia with the tropical ataxic, and some of them are having a combination of both also. And that was attributed to HTLV1.
No, I'll tell you. In TSP, some of the TSPs are due to HTLV1. But actually, what he said is exactly correct. The TAN and TSP, tropical spastic paraplegia, are the two ends of the spectrum. In my study also, some of them, along with the TET, they had pyramidal sites as spasticity.
Yes.
So it's a combination. So one example is a pure TSP, the other end is a pure TAN. In between, they can have any combinations can occur. Yeah.
Yes.
Certainly, the pathogenic mechanism is almost the same in tropical countries. And one of the reasons for the TSP is the HTLV.
Right. Okay. Do you see that in Kerala, any of those cases, in virology proved cases?
No, I'll tell you. In fact, in my MD days, one of the PG's thesis was this HTLV, looking for HTLV virus antibody in the CSF. And this is thesis I found out of about 20 patients, only one patient who is positive for HTLV. In all of this, HTLV was negative.
Right.
Send it to Vellore, and it was done only in Vellore and that time.
Right. Okay. So if we find such sporadic cases, sometime we nowadays diagnose it could be a sporadic HSP variant, like that. Sometimes we diagnose it, the MRI and all doesn't show any leukodystrophy and things like that.
So TSP and HSP mimics the same. Clinically, picture almost the same.
Similar, yes. So which one, should we look in such cases, the heavy metal toxicity also, or only in the TAN kind of presentations only?
No, in fact, regarding the TSP part, logically we should also look for the heavy metal poisoning and things like that. Micronutrients, vitamin deficiencies, P vitamin deficiencies, all should be looked for. Because some other from the Cuba, they found that one of the causes was vitamin deficiency, B1 deficiency causes that syndrome. So many mechanisms have been postulated.
Lead the poisoning also can produce a motor system disease. Right, sir. Yeah. Thank you, sir.
And in some places it's epidemic, I heard.
Ruba, I did not listen.
In some places it's epidemic.
Yeah, it's epidemic. There's a Cuban epidemic of that's due to the nutritional deficiency producing epidemic of tropical attacks in Europe.
Sir, cassava and tapioca are one and the same, sir? Really?
It's one and the same.
Okay. Sir, and also I wanted to ask you, in the first case, where you showed a young boy with multiple hypertensive bleeds and like hypertensive
Binswanger's disease,
Yes, sir. In that patient, sir, did you look out for any pheochromocytoma or any other reasons for hypertension?
No, because I did not look for it, because the patient is actually belongs to the physician. So his investigated for a hypertension, young onset hypertension. I did that. And what investigations they underwent, I do not know, frankly. So in fact, it was referred to me seeing the CT picture. That was intriguing me.
Okay, sir.
I did not do a workup. I did personally not do a workup for the young onset hypertension.
Okay, so I just want to ask you, like any pheochromocytoma, anything was there predisposing?
They must have looked for it, because it's seen by my own classmate, Dr. Josman. He's a very good, very senior physician. He would have looked for everything.
Yes, sir. Thank you so much, sir.
Coming back to this tapioca story, just one more point. Is there any way we can sort of suspect high arsenic or anything by any morphological appearance? Because some of the tapiocas, my grandmother used to say, if it has got a blue coloration, it is poison. We should not throw it away when we plug it from underneath the ground. So is there any kind of warning or any?
Because I have extensively studied this tapioca, so I know each and every one of them. So it all depends upon not only the type of tapioca, the nature in which the tapioca is processed and cooked. Now, if you consume tapioca powder, it will be more hazardous rather than those who steam the thing and then drain the fluid away. There will be less toxic than they take a tapioca powder. In Nigeria and other places, also in some Kerala parts also, parts of the Kerala, they dry the tapioca. They dry the tapioca and make it a powder. And with that powder, we make puttu. Puttu means, what do you call it? I don't know. Malayalam we call puttu. The one you put
I know, sir. Like idli, it is there in the cylindrical thing.
Yeah, steam. So they put out of the tapioca powder. So that has got more toxicity than the one which you conventionally take tapioca. We take tapioca, we boil it in hot water for some time and throw away that water. So that drains away some of the toxic element. So these all these all the things which can influence the toxicity of tapioca. It's not only
by what you said earlier, I thought it was arsenic in the tapioca which was causing the problem. It's not. It's something else also, sir, in the tapioca which is causing problem.
So if it was causing, why should they affect only some people, not all the people? In Central Travancore, everyone consumes tapioca. Only some of them will get that. Some other factors.
So there is no specific belt where this.
There's a belt. There's a central. Yeah, there's a belt. Because after coming to Trivandrum, I have not seen a single case of TA.
Oh, okay. So in that belt also, only some get it, others do not get it.
Yeah, exactly.
So probably it is there in the soil, and wherever the tapioca is grown in the soil, it has more arsenic content and it causes problem.
Right.
Problem.
Okay then. Yeah, I think we should
thank you so much.
Allow you to take some rest. It was great, sir. Thank you very much.
Okay, thank you. Good night.
Thank you, sir.
Thank
Good
you.
night, sir.
Good night. Good night.
Good night, sir. Bye.
Good night.
Good night, everybody. Bye.
Bye.